Lung protective ventilation. I think a pretty much important topic. PGs love it, examiners love to ask it, isn't it? And we all are like sort of post-COVID, we are all overwhelmed with the topic. So what is traditionally a lung protective ventilation? Any PG? Just to break the ice. What's a lung protective ventilation? Low tidal volume. Okay, low tidal volume. How much low? To 8 ml? 6 to 8 ml of? What weight? Ideal or predicted body weight. We'll talk about that also. Then, that's only one part of it. So traditionally the concept has been a low tidal volume, 6 to 8 ml predicted body weight. The concept initial focus was on PEEP Plateau, 30 centimeters of water to keep it less than that. As sir says, now it's more about driving pressure and mechanical power. And that is what we understand. And some PEEP, isn't it? That some PEEP becomes very important. Till that, we have not got a correct answer as to how much PEEP. Okay? But it is very clear that ZEEP is not recommended. ZEEP is zero end expiratory pressure. So if I have to answer it, it's basically a 6 to 8 ml per kg of this thing, some amount of PEEP titrated to the patient, and then the third thing is a plateau pressure. This was traditional definition. And then we'll see what beyond all these things we can talk about in lung protective ventilation. Okay, so again, मैंने anesthesia करना है. I am going to ventilate these patients maybe for a couple of hours. 90% of my patients are going to be in a normal patients with no bad lungs. Now with segmental spinal anesthesia coming, I will not even ventilate them further. And so why do I need to know this thing? We'll come to that part. Post-operative pulmonary complications, VILI and trauma we'll talk about. Now the traditional concept of LPV, that is lung protective ventilation, what it was there. And then let's see what about add-on to the LPs, like what we do during induction, what we can do during maintenance, and what we can do during extubation. I am not going to deal about lung protective ventilation in ICU. There is a lot of similarity, but yes, there are a lot of differences also. We are going to talk about lung protective ventilation in operation theater. We are not going to talk about other ventilation strategies or anything at this point of time. Now, what is PPC? You all need to, exam-going students, you all need to know these topics. What is MACE? MSE? Major Adverse Cardiac Events. What is PPC? Post-operative pulmonary complications. These are two topics. कोई भी तुम्हारा long case चला जाए, short case चला जाए, people will be asking you. ठीक है? So post-operative pulmonary complications can be seen almost in 5 to 30% of the cases. Mortality in some of this series have been shown to be almost touching to the 20%. Imagine the number of surgeries which are being performed, and then this number becomes really very important. It's the second most common complications after surgical site infection. That much important it is, isn't it? It's a high healthcare related costs are there, and it's underappreciated. That is the most important thing. We don't see, or we don't appreciate what we don't know, isn't it? So we need to know what exactly it is there. What is, it's slightly on this side. This is basically VILI, VALI, and basically CILI. What it is? Just exam going some terms. VILI is ventilator-induced lung injury. What is VALI? Ventilator associated lung injury. अब ऐसा क्या हो गया भैया, induced हो गया, associated हो गया. Why so much of unnecessary drama to this thing? VILI is basically, they say it's primarily not used nowadays, but it's predominantly ventilator-induced thing. So the causal association, they say, probably is there. But when you talk about VALI, ventilator-associated, you don't know whether it's basically ventilator it is causing the problem, or it's the patient's primary response or something, but ventilator is a standby there, we don't know. And basically CILI is self-induced lung injury. Again, it becomes a bit of complicated definition, but if you look at the literature, all these terms have been used interchangeably. Okay? You need to know these risk factors. More than 6 ml per kg of predicted body weight. You start doing this, your patient goes into VILI. Blood product transfusion, you will require this in operation theaters. Acidemia, again very common in OT. So basically you are having all these factors when you are ventilating. The traditional concept of lung protective ventilation came from ARDS. Which is the important trial for ARDS? All of you should know this, exam going. ARDSnet trial, isn't it? From where it came. But then slowly they have said that this concept is equally important to your normal lungs also. So we'll see into that particular thing as to how it is there. So we talk about 4 or 5 different types of trauma. Sir has talked nicely about Barotrauma, volutrauma. Basically, if you look at this thing, for every 6 ml above using your per kg body weight, your chances of VILI increases by almost 1.3 odds ratio, isn't it? So that becomes very good. Atelectrauma, your alveoli are closing, opening. Closing and opening. This is causing shear stress onto them. They are causing shear stress onto the next set of alveoli which are there. So this is basically atelectrauma. This is going to be there, but our idea is to decrease it. Then we talk about biotrauma. When you are doing a ventilation for this patient, your patient will be released a lot of cytokines which can be harmful. Now, very important. Again, the question is, मैं तो 1 या 2 घंटे के लिए ventilate कर रहा हूँ, उसमें कौन सा फर्क पड़ता है? There's a nice article. Changes in serum cytokine levels can occur within 1 hour of a change in ventilatory strategy, and it becomes very important. And then there is something what we call it as a ergotrauma. This is something which you need to know. Yeah? So, especially from exam point of view, कुछ चीज़ें होती है मैंडेटरी है सो द रिमेनिंग 4 trauma you need to know, but there are something like desirable you need to talk about this thing. So prolonged elevation in mechanical power. When we talk about driving pressure, mechanical power has been associated with increased mortality. So people have gone from the concept of, say, plateau pressures, driving pressures, and now we are talking about mechanical power. So what is the mechanical power? It's basically a constant multiplied by tidal volume, multiplied by respiratory rate, and multiplied by something your driving pressures. So not only it incorporates your driving pressure, but suppose a patient is requiring a very high respiratory rate, it is adding to your mechanical power. You are requiring a higher tidal volume for whatever reason. You are not able to maintain your carbon dioxide levels, you need to go up on that thing. It is adding to that thing. So remember, it's difficult to calculate on the anesthesia machine, but at least if you know, when I increase my tidal volume, when I increase my respiratory rate, and when I increase my driving pressure, my mechanical power increases, which is bound to cause VILI, VALI, or whatever you want to call, but basically lung injury will be there. Now we are talking about normal lung. This is basically a very nice article. Protective mechanical ventilation in the non-injured lung. If you look into non-injured lung, and this is a protective ventilation, standard ventilation, you see at atelectasis, mortality. Again, you look at the lung injury, lung infections, they are all increased when you don't do a standard ventilation. So basically a nice NEGM article, it has been shown now that lung ventilation, lung protective ventilation is very important even in your routine so-called healthy lungs. So this is something which we should be doing. So basically, we should not talk about 500 ml of tidal volume as a routine. We should not talk. This is something which we have already covered, and I'm not going to go into detail. Now, bit of ventilator modes. जब हम modes की बात करते हैं, we say volume control mode, we talk about pressure control mode. Now there is a slight difference. When we talk about this thing, there are two important concepts we need to understand. See, basically, if I have to look into this thing, there is something called as a spontaneous mode, and there is a control mode. Look at these two important things, rate and power. Rate is how much frequency the ventilation is breathing. So in spontaneous breathing, like what you and me are doing, the rate as well as power, both are decided by the patient. And if you look at the other end, that is the control, the rate as well as power, both are being decided by the ventilator, that is by us. So we do this something, हम routine spontaneous patient को लेते हैं, we induce that patient, we give muscle relaxation, and we sort of put him into a control mode. Now there is something called as an assisted mode in between. This is very important for your ICU purposes, isn't it? Here the rate and power is slightly different. The rate is basically patient. The patient is triggering the ventilator, but you are deciding on how much power, मेरे को कितना tidal volume देना है या pressure देना है, based on that thing. And then there is something called as an assist control mode. Here what happens is, you have two components into the rate. You decide on to a minimum rate. अगर इतना rate patient ने नहीं लिया, तो I am going to give a backup sort of thing, and then you talk about additional rate. The important thing is, in assist mode, assist control mode, and control mode, the power is controlled by the ventilator. Clear? So now, based on this thing, if you remember the diagram, inspiration, expiration, it will become your pressure control mode or your dual modes. Now there is something again called as a dual mode. We all have fantastic workstations in most of the places, but we don't use them. We generally tend to be a volume controller, pressure controller. We have modes like dual guarantee wala mode, isn't it? Where we say ki I want to use best of both worlds, isn't it? I want to have a minimum volume guarantee, ki say 300, 350 jayega, but I want to do it with a minimum pressure, isn't it? So this is basically a volume control or a volume guarantee with a pressure control mode. So this dual mode becomes very, very important. So now how do I set it? This is the Tidal volume. It's available on the web, so I'm not going to talk about this thing. But basically, for a rough scenario, especially from Indian scenario, if you look, females probably would require, if we are talking 6 to 8 ml, the Tidal volume will be 265 to 420, and for males, 280 to 450. There is no number of 500. So this is one thing we need to change into our day-to-day practice, basically. Okay? Then second is how much FiO2, how much PEEP, and how much respiratory rate. So we'll talk about this thing. So decide on your mechanical ventilation, talk about invasive versus non-invasive, talk about partial versus full support, then the 4 things which we talked about, and then you decide about mode, volume, and pressure. One thing which is very clear so far is there are a little bit of literature supporting one mode over another, but till date there is no class 1 indication as to this mode is better as compared to this mode. It's your familiarity with the mode, and if you understand what I'm looking to monitor. If you are doing a volume control ventilation, you need to understand कि मेरे को pressures पे ध्यान रखना है. If you are doing a pressure control ventilation, सब बढ़िया है, and if you don't look at your compliance changing, and if you don't look at your tidal volumes, it is almost as useless, isn't it? So this is the trial which we are talking about, a trial of intraoperative low tidal ventilation in abdominal surgery, which changed the practice. That they said that in your routine day-to-day lung ventilation, normal abdominal surgery without any problem, if you don't use a low tidal volume ventilation, you will have more and more complications. Traditionally, we used to go even up to 10, 12, 15. I have seen literature where they say 15 to 18 ml of tidal volume was being used. In the effect, probably it will create a good oxygenation, but we all understand it has gone into this thing. This is one very nice article, a BJ, it's a lung protective ventilation for surgical patient, international expert-based consensus recommendation. So predominantly onto this thing. Last few slides from my side, last few points into my thing. So when I say lung protective ventilation, हमने 3 component देख लिया, ठीक है? What we need to understand is, I have to maintain a certain amount of recruitment. My lungs have to be kept open. Secondly, I have to sort of neither over-distend my alveoli, nor allow them to completely collapse it up, so that my atelectrauma comes down to a minimum. And this has to be done all into keeping into mind that I need to be aware about the 5 different types of trauma. So now, again, other than these 3 things, that is your low tidal volume, PEEP plateau pressures, and PEEP, some amount of PEEP. What are the other things which you can look into? So these are basically 7 or 8 important things. Pre-operative risk assessment for post-operative pulmonary complication. Many scorings, but probably this is something you can remember. I still didn't understand this because ASA physical status more than 2. It's again a very broad sort of criteria. But take it with a pinch of salt. And if you have these particular patients in this thing, in your OT, you need to be aware that they are highly prone for post-operative pulmonary infection. Intraoperative atelectasis. What is intraoperative? What is atelectasis? It's a collapse of lung for whatever reason, है ना? And this is very commonly ignored. आप कितने बार देखते हो पोस्ट ऑपरेटिव पेशेंट है, हल्का सा ओबीज है, सब बढ़िया थी, एक्सट्यूबेशन अच्छा हुआ, सर रूम एयर पे सैचुरेशन जो है सर 88, 90, 92 के आसपास में, द मोमेंट आई पुट हिम ऑन ऑक्सीजन इट्स स्लाइटली गोइंग अप. व्हाट इज हैपनिंग इज bases are completely collapsed. You start doing an incentive spirometry, you start mobilizing the patient, do some head up and put some BiPAP or CPAP, 2, 4, 6 hours, this patient starts improving. 90% of our patients will have some amount of atelectasis undergoing GA. It will persist for weeks. Its effect will be seen in some high-risk patients. And our idea is, if not to reduce it completely to 0, at least to see whatever we can do, isn't it? So that becomes very important for us. So how do I reduce my atelectasis? Positioning. We say obese patient needs to be doing a ramp up wherever possible. Even normal patients, they also need to be slightly made 30-degree head up position. What will happen if your cephalic displacement of diaphragm will be there? That pressure difference between thoracic and abdomen cavity goes down completely. आपने muscle relaxation दिया, आपका diaphragm sort of complete flat हो गया, and your thoracic and abdominal pressure becomes same. जो नीचे के आपके basal segments है, they have a tendency to completely collapse. So right at the induction, you are collapsing your alveoli. ठीक है, so that becomes a problem. So probably position will help this thing, and again it will give you a longer apnea time by increased FRC. Now NIV during pre-oxygenation. हम लोग NIV कहाँ से लाएंगे अभी बताइए? So what we do is we daily do a NIV. You take your closed circuit or bench circuit, whatever you're using, you give some amount of APL valve or PEEP valve. If you have a circuit which is tight enough, that is acting as a CPAP, isn't it? Say I have given a 5 to 7 of APL valve, that is basically a CPAP of 5 to 7. This thing, so automatically I am using this thing. So this becomes very important, that NIV during pre-oxygenation is much better than simple your nasal cannula or simple face mask oxygen. So this becomes very important. NIV plus head up, it has synergistic effects. It increases your FRC, it increases your oxygen reserves. Then nasopharyngeal airway, it's very, very important. Advantages of nasopharyngeal airways, you can use it early. Gag reflex doesn't become a problem. Oral airway has a gag reflex problem. आपका obese patient है, collapse हो रहा है, lung का volume loss हो रहा है, then you are sort of giving a flush, trying to do a bag and mask ventilation. Try and use a nasopharyngeal airway to prevent airway collapse. And this is all supported by literature. Not class 1, but yes, there is a significant amount. Now the next thing is low tidal volume. But what I have written is, it's not only low tidal volume, it has to have a adequate PEEP also with it. That becomes very, very important. 6 to 8 ml per kg. And adequate PEEP. What is important is no zip. हम लोग ट्रेडिशनली क्या करते हैं, 400 350 टाइडल वॉल्यूम अब हम लोग करने लगे हैं, बट वी स्टिल कीप PEEP at a zero level. That is not there. Minimum PEEP of 5 centimeters should be kept, and based on your which type of surgery you are doing, you will have to individualize it. Laparoscopic है, severe head टेंडनबर्ग आप हेड लो दे रहे हैं, उसके बाद में आपके ओबेस पेशेंट है, probably 8 centimeter 10 centimeter you will have to keep. How to titrate individual PEEP is something difficult at this stage. Probably in the workshop we'll try to cover it. Now there is no difference between high and low level of PEEP, but no zip is problematic. And again, as I said, so change in driving pressure becomes more important. Suppose 500 ml का tidal volume है, मेरा PEEP Plateau, what I was just explaining sometime. So I can titrate my PEEP to a same level, जहाँ पे मेरा tidal volume तो कोई difference नहीं पड़ रहा है, but my pressures are coming down. So my driving pressures become very, very important. Then FiO2, as sir was talking just now, in the low flow anesthesia, it becomes very much of problem. Induction के time में, we are keeping a high FiO2 for obvious reasons. But as soon as I am getting into my maintenance phase, my FiO2 should drop down to 30-40%. A minimum FiO2 to keep normal oxygen. That is what sir was talking during his lecture, that we don't need that much of oxygen. We have 4 times of reserve in our bodies. So probably 30 to 40 is important. But if you are not using a metabolic flow or a severely low flow, say for around 0.5 or 1 liter, a 30 to 40% of intraoperative FiO2 is very important. We all know about increased oxidative stress, but we are not very much about coronary artery vasoconstriction. There have been n number of trials. Cardiac arrest के बाद में, resuscitation के बाद में, cut down on your FiO2. Your cardiac output decreases, your contractility decreases, isn't it? So this becomes a problem. Resorption atelectasis, again, is a huge topic we need to look into. Modes, as I said, no clear difference. Then the last thing is recruitment maneuver. I have induced a patient, and when I'm inducing a patient, because I'm giving a muscle relaxant and everything, I'm expecting there will be some amount of atelectasis. Now the question is, do I recruit the lungs? Recruitment देखा है कैसे करते हैं? Recruitment is basically giving a good amount of this thing. Now that recruitment can be dangerous if not used. This is probably one statement out of all this statement where there is no clear consensus. So the idea is, do not use recruitment routinely, but if you think your hypoxia is creating a problem, then it should be there. Sarah had done said a very nice thing. Our response to hypoxia is to increase the FiO2. That's not the correct way. अगर मेरे को 40% के साथ में नहीं मिल रहा है, ठीक है, for time being you are raising it because you want to have that oxygen going up, but we need to look into some other reasons. If there is no other reason, your pulmonary mechanics are coming into play, and that needs to be addressed. Simply increasing FiO2, as sir was saying, inhalational agent बढ़ाने से या कम करने से आपका BP नहीं change होता है, वैसे ही simply increasing or decreasing your FiO2, your hypoxia problem cannot be solved out completely. So recruitment becomes very important. Recruitment should be followed by PEEP if you are at all using it. Remember, manual versus ventilator recruitment, hemodynamic instability becomes a problem. आप intrathoracic pressures को बढ़ा रहे हैं. 40 to 50 centimeter of water for 5 to 7 seconds of recruitment. आपके जो lung थे, जैसे गुब्बारे नहीं रहते आपके, थक 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 खुल रहे. So now you are opening that lung. But to maintain that lung in that position, you need to keep some amount of PEEP. So recruitment and PEEP are sort of individual both to each other. PEEP you need to keep definitely, and recruitment only if your patient is hemodynamically stable and if you are familiar with it. Otherwise, simply use a PEEP and everything. Okay. So that's basically, and intraoperatively, as we had already discussed, you need to monitor these various pressures and focus the this thing. Emergence के time में क्या क्या कर सकते हैं? Again the same thing जो हमने induction के time में किया था. अगर head up करके कर सकते हैं, then avoid zip. Now this is something routine suctioning. We do it very commonly. जब तक पेशेंट एकदम ड्राई नहीं होता हम उसको सक्शन करते हैं. इट्स अ नेचुरल फिनोमिनन, यू डोंट नीड. अगर आपके रिफ्लेक्सेस अच्छे से आए, सक्शनिंग शुड बी डिस्करेज. ठीक है. सो व्हाई सक्शनिंग शुड बी डिस्करेज? इफ यू टेक दैट थिंग, योर लंग वॉल्यूम इज गेटिंग लॉस्ट, इजंट इट? योर वोकल कॉर्ड इज ओपन, यू आर सॉर्ट ऑफ सकिंग आउट द लंग, इट्स सॉर्ट ऑफ क्रिएटिंग एन एटलेक्टेसिस. ठीक है. सो रूटीन सक्शनिंग यू नीड टू अवॉइड. प्रिवेंट कॉफिंग एंड अपर एयरवे ऑब्स्ट्रक्शन. हाइपोवेंटिलेशन ये भी बहुत करते हैं कि पेशेंट आउट नहीं आ रहा है, ऐसा थोड़ी देर वेंटिलेटर बंद कर देते हैं, कार्बन डाइऑक्साइड को बढ़ने देंगे, पेशेंट बढ़िया से फिर ब्रीथ करेगा. द मोमेंट यू डू दिस थिंग, जितना अभी तक आपने एटलेक्टेसिस के लिए किया था, यू हैव ब्रॉट इट ऑल डाउन टू द जीरो लेवल, एंड देन पोस्ट ऑपरेटिव एटलेक्टेसिस आप क्रिएट कर रहे हैं. पोस्ट ऑपरेटिव वाई एनेस्थेटिस्ट आर नॉट प्रॉब्लम. मेरे को पेशेंट यहाँ से आईसीयू में शिफ्ट करना है, स्टेबल करना है, बाद में का सर्जन देखते बैठेगा, इंटेंसिविस्ट देखते बैठेगा. दिस इज समथिंग वी शुड नॉट डू. किडनी इंजुरीज, योर सर्कुलेशन, योर हाइपोक्सिया, दिस इज ऑल समथिंग इट शुड बी पार्ट एंड पार्सल. Again, don't keep unnecessary too high FiO2, and can use a post-operative CPAP NIV, especially for obese patient and laparoscopic patients, all these things. I'll stop here, sir. And then, sorry, I have to cover it a bit fast.